Welcome, everyone. I'm Dr. Carmen Pugliafito, and I'm here today with Dr. Mohamed Genead of Nanoscope Therapeutics. She's the Chief Medical Officer. Mohamed, welcome to Retina Synthesis.
Thank you, Cameron, for having me over here. It's a pleasure to be on your pod here, and excited, to give you more background about nanoscope technology and what you're trying to do for our patient with retina degeneration.
Optogenetics is something that's new to the retinal community. Can you tell us what optogenetics is?
Yeah, absolutely. As a retina surgeon, I can tell you, I'm excited about this personally. It's a very novel, exciting technology for our patients with retina degeneration. But let me give you some background, because this is kind of exciting how this started, how the field got evolved. Francis, Crick, who discovered the DNA, one of the co-discoverer of the DNA, he was one of the earlier scientists discussed, the use of light to stimulate or target neurons in our retina and brain. And that was, like years back, right? But nobody, figured out from that time point, what could we do? And there was a lot of research have been done in the neural space, neurobiology, basically, to look at that, as a technology platform. But just, to give background about optogenetics. So optogenetics is basically combining using, a gene transfection or gene therapy and light. And you try to stimulate, a light sensitive protein in your retina or your neurons to be activated by a light source. That could be external, could be, ambient, could be, a different modality people are using right now. That's where the name came from, optogenetic. So it's a combination of the optics and genetic to stimulate our neural tissue. So it's a kind of like a form of neuromodulation strategy.
So you've have an intravitreal delivered AAV2 vector, viral vector, and you're targeting bipolar cells. And how does that work?
So background about the company and the technology in hand. So Nanoscope is a clinical stage company. They are based headquartered in Texas, with a headquarter or like another office in Mass, in Boston area, in Cambridge. But they have a lead asset called MCO010, which is, as you mentioned, it's an AAV-A2 viral delivered multi-characteristic opsons delivered to the unpolar cells inside our retina, and using the technology, the optogenetic. So basically, you try to transfer this light-sensitive material in our, bipolar cells, and using an ambient light, not using, any other, source of light, to activate that, molecule to produce, a visual currency inside our retina. Why bipolar cells? That's a part of the technology and the differentiation of the technology, actually, between, Nanoscope technology platform versus other players in the field. As you know, as a retina surgeon specialist, the unbipolar cells have a larger number in our retina, are present in larger number than the retina ganglion cells, which are the target for the other platform in the field. And that itself will give you higher, spatial resolution, right? That's number one. Number two, the ganglion cells, the bipolar cells also have this more visual processings that will give you even, more, I would say, give you more opportunity, on the visual currency or the photocurrency, and give better, visual also resolution. That's the reason why we are targeting the unbipolar cells and versus the retina ganglion cells, and we have some data showing very exciting, outcomes in patients with retina degeneration.
So essentially, you're converting the bipolar cells into light sensing tissue.
This is correct. So literally, we are regenerating the retina or re-engineering the retina by developing a new photoreceptors for those patients who lost their outer retina structure, right, including the photoreceptors. And that's why the technology have to be used in patients who still have intact neural tissue and retina structures, including bipolar cells. And that's exactly what we're trying to do, re-engineering the retina to develop a new photoreceptors for those patients with retinal degeneration.
And your first target disease is retinitis pigmentosa.
This is correct.
And your approach is also interesting in that it is genotype agnostic. In other words, it doesn't matter what the genetic defect is that's causing the retinitis pigmentosa, optogenetics will work.
Yeah, and this is exciting, Carmen, I can tell you, just going back a few years back when we started the waves of the ocular gene therapy, this was a traditional conventional gene replacement therapy. You go after a gene mutation and you try to replace it with the healthy template and try to correct the deficit or the defect in your retina, right? It's a great opportunity for our patients, but remember, there's a lot of numbers of genes we cannot find. We cannot, genotype this patient. Number two, going after all those hundreds of gene mutation at a time, it will take a lot of time, right? So there's all this limitation with the conventional gene therapy. It doesn't mean it doesn't work. It's a great opportunity for our patients, but it's still, there's all this significant unmet medical need, right? What we're trying to do with our technology at Nanoscope and other people in the field of optogenetics, we try to overcome that hurdle. Like the patients who cannot genotype, the patients, we cannot correct each mutation, altogether. So we're trying to be gene agnostic, or another way, gene independent approach. And by the way, this could not be only applied to retinal degeneration or inherited retinal degeneration diseases. This could be also applied for other retinal diseases that have outer retinal structure abnormality or degeneration, right? Think about it like patients with GA, geographic atrophy, right? And they have the same kind of, it's a different version, right? It's a different mechanism, for the pathophysiology or pathobiology, but the outcome is similar, right? There's similarity in the outcome. You have, the outer retina structure are lost. The inner retina is still intact in most of those patients. So that's what we're trying to do here by applying the technology to restore the vision in those patients with an intact retina structure, inner retina, neural tissue versus the outer retina. And that's what we're trying to do in our first in human in patient with RP. So the first in human trial, we're trying, actually, this is not the first in human, this is the phase 2B. The RP patient population, it's a proof of concept in human. So what we're trying to do in our drug development or clinical development strategy, the RP patient will be the one to show if we're able to achieve that in patient with retinitis pigmentosa. We will apply the same molecule, the same technology in other patients with outer retinal degeneration, including Stargardt disease, Usher syndrome, Conrad dystrophy, even GA patients, geographic atrophy patient. So that's why, we're very excited about the technology. We have to prove it in the clinic, obviously, which we're doing right now.
Can you tell us a little bit about the clinical trial results that you just presented in your first group of patients with retinitis pigmentosa?
Sure. So we had a chance to present this last time at the ARVO. We also plan to present at Retina Society and the American Society for Retinal Specialists, end of the summer. So stay tuned. And so the summary of the phase 1/2A trial we conduct, it was a single center. It's an open label. It was the first in humans. So we were looking at the safety and tolerability of our intravitreal injection of the MCO 010 molecule. And also we looked at some other efficacy measure outcome, including visual acuity using the Freiberg visual acuity chart, hand-free visual field, other, visual function assessment, including, the mobility MACE test, right? Like what other people did in the field. The outcome, it was 11 patients only, and we will mainly patient was advanced stage of retinitis pigmentosa, different gene mutation. It was a gene agnostic, and what we found was quite exciting, I can tell you. First of all the patients have been dosed. We followed this patient up to 52 weeks, 1 year after a single baseline intravitreal injection. What we found after 1 year from the baseline injection, all the patient was, the safety profile was very favorable. We didn't see, any significant, intraocular inflammation. We didn't see any like a long-term immunogenicity changes from baseline. We saw, some events, very mild, moderate events of intraocular inflammation, which is typical with gene therapy, which was very transient, last only for a few days, was treated with topical medication without any long-term sequelae. So the safety profile was in very in favor to advance the molecule. The most important part was the efficacy. Usually, like you not expect to see, much, and this was a big surprise we found. It was a very positive note. We found patients, who received the single intravitreal, it was single intravitreal injection at baseline. We saw many patients actually improved on many visual functions, not only the visual acuity, including the other visual function and measure outcome like visual field, the FST and MACE test. One of the biggest surprise for me to see, I saw, this was like close to 80% of the patient, 80% improved 3 lines on the visual acuity chart, 15 letters. And we have close to 50% of the patient were able to improve at least 6 lines, 30 letters on the visual acuity charts. You have to think about, this is kind of very significant and clinically meaningful, but also remember this patient was very poor acuity, right? So there's some variability, but we use the Freiberg, Logmar Freiberg visual acuity chart, which is very correlated to the ETDRS, which is commonly used in retina therapeutics. So it's a very exciting data. And the trend was very similar in the other visual functions tests we did, like on the mobility test. We did, this mobility MACE test, and we put obstacles in front of the patient and asked him to look, and try to hit the target with different intensity of light. And many of the subjects were able to navigate that easily, especially after 4 months from the injection. So we start to see a positive trend in the efficacy around months 4 from baseline injection. And that trend sustained and became, more pronounced around 52 weeks, 1 year after the injection. So it gives us, a lot of, confidence to move this molecule forward. That's why we are in the phase 2B right now. In US, it's a multi-center double masked trial, but very exciting, data. I'm excited about personally for our patient, and we'll see what's going to happen with the late development trial.
So what did the patients report subjectively about the quality of their vision? What did they?
This is a good question.
What did they say?
Go ahead, Karen, please.
What did they tell the investigators about the quality of their vision?
So it's a great question, and it's an important question because you need, as you know, with gene therapy and also all these patients with retinal degeneration, the quality of life matters for them, right? And we always take, I was telling all the time, my colleagues or my team members, like we take everything for granted, right? We are normal-sighted people, and any small change for us is not meaningful, but for patients with retinal degeneration is very meaningful. So we applied, the NIH, VFQ visual questionnaire, which is very validated and commonly used, in retina drug development. So the patient was describing, overall the composite score of from all the 11 patients we studied. They were very, very positive. They described, meaningful changes in their daily routines, right? Just going, from one room to the other without any assistance. We're able to go, from a little bit dim little places to outside their homes, right? To check what's going on outside. Some patients were able to describe, they were able to see, objects on the wall they were never able to see before, and so on. Actually, we have like a very interesting, and we're going to present this data very soon, a video of some of those patients. They were able to navigate, going outside, walk down the stairs, going outside their, homes or their comfort zone, and on their own, without any support, without any guidance, without anybody around them. And that was very like, when I saw this, was very rewarding, and so patient was very positive, and they described many things. One of them, even the color discrimination, right? They were able to see colors they didn't see before. And I told you the visual acuity was the biggest part because people were able to see, things on the chart again. So they went from off chart to on chart. And that was very significant for a few patients, again, it's a small number of patients, 11 only, but we are trying to look, at more, patient in our, current, phase 2B trial.
So in some optogenetic therapies, the patients wear goggles and use a special light source. Can you talk to us a little bit about the difference between Nanoscope's approach and these other approaches?
Yeah, absolutely. And Carmen, you hit, a very important point, and you're right. For our technology, we're using, this, molecule, this called the multi-characteristic opsin, which is the polychromatic opsins. And basically what Zeus, multi-characteristic opsin can do, they could be activated. And what we found preclinically in our preclinical, and research work we've done before we went to the human, we found we were able to activate the neurons in our retina using the natural ambient light. So the exposure of the light, to activate, our molecules was very, very small. And most of the things what we found was quite exciting, because the stimulation threshold for those neurons were way, way, way higher than, what's required, by nature, right? That's why I believe, with our technology, you were able to really restore some vision. But back to your question about the other technology using this monochromatic opsins, channel rhodopsins, for examples, right? And just physiologically, to activate those channel rhodopsins, you require very intense, high, like exposure to light level, very high intensity of light. And as you know, that on long term might cause, phototoxicity, have been reported in some studies, and also preclinically, high exposure to that intense light on long term can cause retina, phototoxicity and retina neurodegeneration. That's why, the other, technology need to have this external goggles to activate their light sensitive proteins and molecules inside the retina. We don't require that. And that's a very big differentiation in our technology versus the other. And I'm excited about too, because if you're able in our drug development simulate the natural conditions, right? We are living not, like an intense light environment. The natural light, or the ambient light, outside our home, it's not so intense, as the other technology is applying. So we were able to activate our molecule using the ambient light or the natural light, which is quite exciting. And I think that's related to the molecules we're using versus, the other, platform.
Well, this is really exciting. What's the phase 2 trial going to, how many subjects, and has it started yet?
Yeah. So we actually did start, we actually dosed the first patient. I can share with you, I'm very excited about this announcement. We had a press release about that. It was in public domain since July. So we dosed our first patient in July this year, 2021. The study is around 27 patients to be enrolled. It's a multi-center controlled double placebo, study here in US. We were injecting 2 doses of our molecule versus the sham control arm. And the idea to enroll 27 patients, we will be on target. We are planning to be on target, to finish our enrollment. My expectation to be done, by, end of the summer, early fall. And we are on target of that. We already enrolled, 6 patients thus far as we speak today. And it's exciting, so far, everybody, looking great. We didn't see any safety signal. Obviously, it's a double mask, but so far we didn't see any signals. The design of this study was mirroring, the phase 1/2A study we did, last year. The two things are a little bit different. We used, the same highest dose we used in the first trial we're using here, and then we're using 1 dose below, so we can have like a dose ranging. It's going to be the same technique, intravitreal delivery, 1 single intravitreal baseline injection, and follow up for 1 year. And we're including many patients, versus 11, and we're including also patients with a different genetic, like mutation, so we can look at the genotyping versus the phenotypic correlation. And the same endpoint, the main endpoint will be the visual acuity and the mobility testing. Obviously, the safety and the tolerability and the immunogenicity profile and characterization will be of importance to watch. We didn't expect, to see any, but that's going to be a part, of our trial, endpoint.
So what are the entry visual acuities of the patients?
So for this trial, we are designing this, very similar to the other one. So the study eye will be, I would say, LP and hand motion counterfeit. So going to be still, a poor acuity, will be on the low vision acuity. The fellow eye cannot be any better than, like counter finger, in the fellow eye. We obviously will inject in the worst seeing eye. We're not going to use, the best seeing eye in Zeus patients. So it's still going to be the advanced form of RP patient population. And the idea after this trial, maybe for our phase 3 and the late development trial, this is a phase 2B, it's very late. We might include patients who are more better acuity in the study eye. But at this stage, we are focusing on patients with advanced RP.
Well, Mohamed, this is very exciting. Thanks so much for sharing your work at Nanoscope Therapeutics. We're really going to be following this closely. We'll hope to get you back when the results of the phase 2 trial are in. Thanks a lot for your time.
Thank you, Karen, for having me on. Thanks a lot.